Bismillahirrahmanirrahim. The next topic in the vasculitis section is Takayasu arteritis. So just like giant cell arteritis, Takayasu arteritis is also a granulomatous inflammation of large to medium-sized arteries. The disease most commonly affects arch and its branches, including carotid artery, followed by ulnar, brachial, and axillary artery. Takayasu arteritis is also characterized by the transmural fibrous thickening of arterial wall, resulting in luminal narrowing. This narrowed lumen results in weak pulsations of upper extremities, hence the disease is also known by the name pulseless disease. Takayasu arteritis is just like giant cell arteritis in almost all aspects, except there is an age difference. If the disease is occurring in the patients less than 50 years of age, they are mostly classified as Takayasu arteritis, and if the disease is occurring in more than 50 years of age, it is known as giant cell arteritis. So Takayasu arteritis is more common between the ages of 25 to 30 years, and there is a female predominance, the ratio being 8:1. Takayasu arteritis is although global, but it is more common in Asian region such as Japan. Takayasu arteritis is further subdivided into 4 subtypes on basis of distribution and involvement of different arteries. Type 1 Takayasu arteritis is characterized by inflammation of aortic arch and its branches. Type 2 is characterized by inflammation of descending thoracic and abdominal aorta. Type 3 involves complete aorta including aortic arch, thoracic aorta, and abdominal aorta. Type 4 disease does not actually involve the aorta, but rather it is characterized by the inflammation of pulmonary artery. The disease results in irregular and transmural thickening of the artery, which causes marked narrowing of the lumen. As you can see here, this is a cross-section of carotid artery with a marked narrowing of the lumen and excessive thickening of the arterial wall. This thickening is due to granulomatous inflammation and fibrosis. The narrowed lumen leads to a weak pulse of upper extremities, hence the name pulseless disease. The histological features are just like giant cell arteritis, characterized by the presence of granulomatous inflammation, which means there is a granuloma, and there are giant cells as well. These are the giant cells, which are formed by the fusion of various macrophages, and these cells are large, have extensive cytoplasm, and multiple nuclei. The giant cells are typically present in the center of the granuloma. At the beginning of the disease, there is mononuclear infiltrate present in the adventitia, which involves media in the more severe cases. The mononuclear infiltrate includes macrophages, lymphocytes, and monocytes. So due to formation of the granuloma, there is necrosis of tunica media and there is disruption in the elastic lamina as well. Intimal hyperplasia is also present, and the disease typically involves all 3 layers of the vessel wall, hence it is transmural. The disease presents with the vague symptoms that include fatigue, fever, and weight loss. The more specific symptoms appear after the severe damage to the blood vessels, and they depend upon the blood vessel that is involved. In case of the involvement of aortic arch and its branches, there is visual disturbance and neurological defects due to involvement of carotid artery, and there is weak pulse, decreased blood pressure, and upper limb claudication in case of brachial and ulnar arteries. In type 2 Takayasu arteritis, abdominal aorta is also affected, which results in hypertension due to involvement of renal artery, and iliac arteries damage can result in lower limb claudication or leg pain. The diagnosis is established on the presence of clinical signs, raised erythrocyte sedimentation rate, and the angiography reveals narrowing of the lumen of the affected arteries. This here is an angiogram of the patient affected with type 1 Takayasu arteritis, and as you can see, this here is the aortic arch, and there is narrowing and decreased blood flow in the brachiocephalic artery, right subclavian artery, and carotid artery. Moreover, there is also decreased blood flow in the left subclavian and left common carotid artery. The treatment is with steroids and immunosuppressant drugs such as methotrexate and cyclophosphamide. So this brings us to the end of discussion about Takayasu arteritis. If you have any questions, do let us know in the comment section. Thank you.